Nurses play a crucial role in caring for patients on mechanical ventilation. The responsibilities of the critical care nurse include coordinating patient care, evaluating the patient's response to the plan of care, identifying and preventing complications, providing comfort and a system of communication, and eventually weaning the patient from the ventilator.
This is Mr. James Kirkpatrick, 58-year-old patient of Dr. Frank, who was admitted yesterday from the emergency department. When he came into the emergency room, he had been on vacation for a while and had not taken his medications for 3 or 4 days.
What is it he usually takes?
He usually takes Alupent,
Okay.
and he had been in respiratory distress for about 3 hours. Has no history of cardiac involvement. He's not allergic to any medication. His chest sounds had some scattered bronchi with crackles, and they had got a sputum culture from him because he had some greenish type secretions. His blood gases when he got to the emergency room when they took him was 7.28 pH, PCO2 of 50, PO2 of 58, bicarb 28, 90% saturation, and that was on a 100% non-rebreather mask. We intubated him and put him on a tidal volume of 800, an IMV of 10, FiO2 of 40%, and 5 of PEEP.
Is he breathing at all on his own with that?
He's breathing just a little bit. His respiratory rate's about 10, 12. His blood gases after we intubate him were much better. A pH of 7.42, a PCO2 of 41, a PO2 of 94, a bicarb of 28, and an O2 saturation of 99%.
And what's his own tidal volume?
His tidal volume's 600. He got Valium 5 milligrams before we intubated him. He hasn't had anything since then. His vitals are stable. Heart rate is in the 80s, sinus rhythm. Blood pressure is 150 over 90. And respiratory rate is, like I said, 10 to 12. And he's much more relaxed and much quieter.
What do you have running his IV?
And his IV, we got lactated ringers at 100 cc's an hour.
Okay, and we just have the right forearm.
Yeah, he's got the right forearm. He's nice and pink. He's looking real good, smiling at us.
Hi.
Yeah. So
I'm
you're
your
gonna-
day nurse. My name's Nanette.
Assessment focuses on both the patient and the ventilator.
Mr. Kirkpatrick, I'd like to let you know what we're going to be doing today. We're going to place a central IV line in you, which is an IV line that will be placed either over here or here. This will give us access for giving you nutrition. You're not able to eat or drink when you're on the ventilator. You've already been started on antibiotics because your chest x-ray indicated that you have a pneumonia, and we will be continuing the antibiotics. Now, you're not able to speak because of the ventilator, so I have a little board for you here that you can write on. Do you have any questions right now for me? All right, then I'm going to go ahead and check you out from head to toe and do an assessment.
First, the critical care nurse assesses the patient's level of consciousness. Any change can be an early sign of hypoxemia or hypercapnia. If the patient is anxious, confused, or agitated, the nurse may suspect hypoxemia. If he's sleepy, it could be hypercapnia. This part of the assessment is particularly challenging in that the patient has an endotracheal or ET tube through his vocal cords and can't speak.
Can you open your mouth so I can check your mucous membranes?
Next, the nurse evaluates the patient's color. If he's hypoxemic, his oral mucous membranes and lips may be pale. A late sign of hypoxemia may be peripheral cyanosis, a bluish tinge to the nail beds, nose, ears, or fingers. Of course, the condition may also result from exposure to cold, vasoconstriction, or vascular occlusion.
Do you have good sensation down here? You can feel my hands? Great.
Patients on mechanical ventilation must have their breath sounds auscultated frequently. The nurse auscultates Mr. Kirkpatrick's lungs anteriorly, laterally, and posteriorly, comparing breath sounds from side to side for adventitious sounds, crackles, wheezes, or rhonchi. If the breath sounds are decreased or absent on the left side, the nurse is concerned that the ET tube may have moved into the right mainstem bronchus, or that he has developed a pneumothorax. In addition to the breath sounds, the patient's respiratory rate, depth, and rhythm are assessed.
And listen through the back if I can help you sit forward for me. You able to hold yourself upright? I'm going to check your respirations.
For a patient on mechanical ventilation, the respiratory rate is counted for 1 full minute, and all breaths, the ventilator's and the patient's own, are counted. The nurse also checks the blood pressure and pulse.
And we'll get your blood
Some
pressure.
patients may have become hypotensive and tachycardic when mechanical ventilation is first initiated and may require fluids. Generally, this is seen with volume-depleted patients.
Your vital signs look good. I'm just going to check your ET tube right now.
To determine if the ET tube is still in its proper place, auscultate breath sounds and evaluate the chest X-ray. Also, the ET tube has marks on it to determine placement. The nurse notes the centimeter number at the teeth and by routinely checking the mark can identify tube movement. In order to avoid excessive pressure on the tissues of the trachea, most ET cuffs are high-volume, low-pressure. Some clinicians use the minimal leak
First, I'll listen at
technique,
your
whereby
throat to
you
see if I can
auscultate
hear
the
any
trachea
leak.
during inspiration and inflate the cuff just enough to keep air from leaking around the cuff. The pressure is verified with a manometer to make sure that it is not greater than 25 centimeters water pressure.
I hear just a little bit of air escaping, so we'll check the pressure on your cuff. Just slightly low, so I'm going to add some air to it. Perfect. I'm going to check your ventilator now.
As a critical care nurse, you'll be responsible for verifying the ventilator settings, including the FiO2, tidal volume, mode, rate, and anything additional, such as PEEP or pressure support. Make note of the peak inspiratory pressure and the temperature within the system, and check to see that the alarms are on. Patient safety is, of course, a #1 priority. Each day, the patient is weighed and intake and output is calculated to assess the fluid balance.
I notice you're coughing, so I'm going to suction your lungs to get that mucus out. Can you bag for me?
Coughing is one way to determine that a patient on mechanical ventilation needs suctioning. Another way is by evaluating breath sounds. Crackles or rhonchi may be caused by secretions in the airway. Before and after suctioning, always perform hyperoxygenation with 100% oxygen for 3 breaths to help prevent complications. During suctioning, alarms may be silenced but must remain on.
This will make you cough.
Monitor the oxygen saturation and cardiac rhythm during the procedure.
All
The
right,
suction
let me
catheter
put it
should
on
be in the
again.
ET tube no longer than 10 seconds. The patient is given several ventilator breaths before suctioning is repeated. When suctioning through the ET tube, use sterile technique.
All right, I'm going to get the secretions out of your mouth now. Can you open your mouth for me?
Following ET suctioning,
All right.
use the suction catheter to remove secretions from the oropharynx. If additional suctioning is needed through the ET tube, use a new sterile suction catheter. Patients on mechanical ventilation need meticulous oral care.
I'm going to do your mouth care now. You don't need to worry about the fluid because I'm going to use this sponge that's connected to suction.
If the patient is nasally intubated, the teeth can be brushed without any interference. Special toothbrushes that attach to the suction are available to help remove secretions. In some cases, your patient will also have a bite block to prevent biting on the ET tube.
Can you open your mouth for me? I'm going to put a little bit of lubricant on your lips.
Even if your patient doesn't have teeth, the mouth is lubricated and rinsed, and the lips are lubricated regularly.
Now that we're done with the mouth care, I thought what we might do is untape your tube and reposition it to the other side of your mouth. We do that every 24 hours, and now would be a good time since we've gotten the tape wet with the mouth care. Julie here is going to help me by holding the tube. All right.
If, like Mr. Kirkpatrick, your patient is orally intubated, you'll want to move the tube from one side to the other every 24 hours to prevent irritation and pressure injury. To do this, you'll have to retape the tube. As a safety measure, this requires 2 people.
Move the tube to the other side of your mouth. All right. Very good. All right. Thank you. You've had a pretty busy morning this morning, so I think what we'll do is reposition you and let you take a nap for a little while. Before I do that, I need to empty the water out of this tubing. So I'm going to disconnect you for a moment and empty the water. As I do that, I want you to take some deep breaths.
Since immobility can cause unnecessary complications, it is necessary to reposition mechanically ventilated patients from side to side. Of course, some patients will tolerate one position better than another. The head of the bed is usually maintained at 30 degrees to help prevent aspiration. Check to be sure the ventilator tubing is free of condensed water.
I'm going to have you turn towards your left side. You can bring this arm up.
When repositioning the patient, monitor the pulse oximeter for changes in oxygen saturation.
Lean back against the pillow. I'm going to place this pillow between your knees.
Carefully move the ventilator tubing with the patient to prevent airway trauma and extubation. Be sure to keep the side rails up at all times.
those tubes pulling? I'll leave your call light with you here, and if you need anything, just press the red button. I'll check on you in a little bit.
The nutritional needs of a patient on mechanical ventilation should be evaluated with the help of a dietitian. Patients need enough calories to prevent muscle wasting, but a high carbohydrate diet can increase CO2 and make weaning difficult. If the gut is functioning, the patient should be fed enterally. If not, total parenteral nutrition is an alternative.
For now, this IV bottle here will give you all the vitamins, calories, and protein you will need. When you do start a diet, you'll be on liquids at first, and then we'll progress to solid foods.
How many calories is he getting in his TPN and intralipids in a day?
2,400. When do you think we'll be weaning him?
Well, as pneumonia's resolving, we'll probably be weaning him in a day or two. At that time, we'll check arterial blood gases to make sure his CO2 level isn't elevated due to the high glucose concentration in the TPN.
Okay, then. I'll check back tomorrow. Goodbye, Mr. Kirkpatrick.
You're getting much stronger now, and by tomorrow he ought to be able to sit up in a chair. But while you're visiting with your wife, it would be a good idea to do some range of motion exercises with your arms.
While patients are critically ill, it's important to maintain flexibility and strength. Establish a plan for both active and passive range of motion that progresses to sitting up in a chair. Remember, the intubated patient cannot speak and must be provided with a method to communicate his needs.
I've put these soft restraints on you so that if you wake up in the middle of the night and you forget where you are, you won't pull your tubes out. If you need anything for sleep, I can get you something. Just put your call light on, and that's the nurse button right there. And I'll be right out here if you need me. I'll be checking on you.
For sleeping
frequently.
patients or those who are disoriented, consider soft restraints to prevent self-extubation. A family member might want to sit by the patient's bedside and hold his hand to reassure him. Sometimes patients need sedation to tolerate the tube.
Kirkpatrick, do you feel like you're getting enough air? I'm going to give you a few breaths manually with an ambu bag.
Always respond to ventilator alarms. Sometimes you'll be able to readily identify the source of the alarm. Other times, the cause will be less obvious. If that's the case, disconnect the patient from the ventilator and use a manual resuscitation bag with 100% oxygen to ventilate the patient until someone can help you troubleshoot.
Could someone call respiratory therapy, please? We'll be here in just a minute. Feel like you're getting enough air now?
We've already turned down the rate on your ventilator, so you've been doing quite a bit of the breathing on your own. Your heart rate and blood pressure have been really stable, and your oxygen saturation's been great. So we're going to move on to the next step of weaning now. This is our respiratory therapist, Lily.
Before removing a patient from mechanical ventilation, a number of criteria must be met. Heart rate, hemoglobin, blood pressure, and blood gases must all be acceptable. The primary medical condition must have stabilized. The overall condition must be optimized, and the patient must be ready psychologically. And you must be certain that there's enough cardiopulmonary reserve to maintain spontaneous ventilation. Here are some guidelines. A vital capacity of 10 to 15 milliliters per kilogram is ideal, but patients with chronic conditions and normally low vital capacities may do well with less. A spontaneous resting respiratory rate of less than 30 breaths per minute. The ability to generate an inspiratory force of at least -20 to -25 centimeters water pressure, and the ability to double the resting minute ventilation on demand.
Good. I'm going to hook you back up to the ventilator now. You did really well. I'm going to go and get the equipment and we're going to get you on T-piece.
Great. I think you'll be a lot more comfortable. Do you feel ready? Okay. I'm going to disconnect you from the ventilator now and place you on the T-piece. You'll be breathing on your own, but it will be providing you with humidified oxygen.
Patients can be weaned from the mechanical ventilator using a variety of techniques depending on the underlying condition, the length of the time they were mechanically ventilated, and clinician preference. The patient may be given humidified oxygen through a T-piece connected to the ET tube. The patient is still intubated but is breathing on his own. Other patients are weaned as the rate of mandatory breaths, or the amount of ventilator breaths, or the amount of ventilator pressure is gradually reduced. Regardless of the weaning technique used, the patient's closely monitored and given ample emotional support. It's not uncommon for the patient to feel anxious and to experience shortness of breath at first.
Look like you're getting a little anxious. I want you to just try to relax and take slow, deep breaths. And be monitoring you very closely. I'll be watching your heart rate, your respiratory rate. I can see your oxygen level on the SAT monitor at all times. So just breathe nice and slow and deep and relaxed. I'll be here through the whole process. Good. That's better. Very good. We'll be checking a blood test in about a half hour. That's the next step. Very good.
If the patient is not tolerating the weaning process, you may see a respiratory rate greater than 30 or less than 8, or an increase in 10 from the starting respiratory rate. Other signs include agitation, diaphoresis, nasal flaring, paradoxical motion of the rib cage, a change in heart rate by 20 beats per minute, dysrhythmia, or changes in oxygen saturation.
Just breathe nice and slow and relax. Feels a little different, I know.
If the ABGs are good and the patient's doing well after a predetermined time or a number of trials, the patient may be extubated.
You have really improved since yesterday. Your room is ready downstairs, and they'll be here soon to take you down in a wheelchair.
You were wonderful, really. I really thank you very much.
Oh, you're welcome.
Yes, thank you so much.
You're welcome. Now make sure when you get down to your new room, you continue to do your breathing exercises.
I promise, really.
Mosby, providing innovative products and services dedicated to publishing excellence.